Impact Manager for GHC's Community Impact Manager for East Africa, and I'm excited for today's discussion with our exceptional panelists and moderator. Telehealth became a basic need for the general population, healthcare providers, and patients. Its need was greatly emphasized during and post the COVID-19 pandemic, especially when people are in quarantine, enabling patients in real time through contact with a healthcare provider for advice on their health problems. There are various benefits to using technology of telehealth, especially in non-emergency routine care and in cases where services do not require direct patient-provider interaction. However, there are barriers to implementing these programs. In this discussion, we'll talk about what is the role of telehealth services in preventing, diagnosing, treating, and controlling diseases. How has the COVID-19 pandemic affected the adoption of telehealth? What are the barriers to accessing telehealth? And what are the ways to bridge these gaps? It's my honor to introduce our moderator today, Jonathan Mutwala. Jonathan was a fellow in 2012-2013 in Malawi and placed at the Clinton Health Access Initiative as an early infant diagnosis system analyst. Jonathan is currently the ICT and e-health manager at CHAI, Malawi, supporting all ICT systems for the office, e-health initiatives, and diagnosis program activities. Jonathan has been a key person in the implementation and the scale-up of early infant diagnosis and viral load laboratory management information systems, which is currently running in 53 molecular laboratories across Malawi. He has also played an active role in the implementation and scale-up of EID and VL testing in MPIMA devices and GenExpert machines in Malawi. Jonathan has supported several digital health initiatives implemented alongside research activities. He has an mHealth. He was an mHealth lead person for the implementation of promoting retention in infants and mothers effectively, study supported by World Health Organization. He has also supported the implementation of an operation research titled Feasibility and Impact of Near Point of Care, Integrated Tuberculosis and HIV testing in Malawi and Zimbabwe. Jonathan will be introducing our panelists today about the discussion on telehealth approaches and services, telehealth and health equity, and the opportunities for telehealth post and during the COVID-19 pandemic. I hope everyone on this line will also share your insights, comments, and questions in the chat and Q&A box. We hope to get as many of them as possible. Jonathan, Aaron, and Brian, and Jenna, who will be joining us shortly. Thank you again for joining us. Jonathan, I will pass it to you to introduce yourself and our panelists today. Over to you, Jonathan.
Yeah, thank you so much, Anita, for that great introduction. As already said, my name is Jonathan, and my name is Jonathan, and quite a lot has already been said by Anita in terms of who I am professionally and the experience that I've gathered over the last decade in implementing technology and working with healthcare workers in so many areas of serious impact to people in Malawi. So my job this time around will be to introduce the panelists and moderate our discussion. So I will begin by introducing Gina. So Gina was a fellow, GHC fellow in 2017-2018, working in the US. Placed at Dot House as a communication and development associate. She most recently led digital strategy and telehealth for New York Presbyterian Division of Community and Population Health, which operates 90+ primary specialists and behavioral healthcare sites, serving around 170,000 medical aid and Medicare patients. And at the NYP, Gina's work included the expansion of telehealth before, during, and beyond the COVID-19 pandemic, the introduction of online scheduling, the COVID-19 vaccine outreach. So Gina has worked extensively on the patient adoption of digital solutions in patient care settings. Beyond her work at NYP, Gina serves as serves on the Global Health Corps US Alumni Board as a sexual assault and violence intervention advocate in New York City Emergency Department. Gina is now an MBA MPH candidate at Dartmouth School of Business and Dartmouth Institute of Health Policy and Clinical Practice. Her passion is improving healthcare and social services with a particular focus on accessibility and design of digital solutions. So quite an amazing biography for our panelists, Gina. And then my second panelist is Brian Senoga. So Brian was a fellow in 2013 to 2014 in Uganda, working with EGPAF as a communication and documentation officer. He's passionate mostly about developing young leaders and ICT for development. Brian currently serves as a partnership specialist for African region with the MEDIC, and he's based in Kampala, mainly overseeing the adoption of Community Health Toolkit as a platform of choice for public and private sector community health programs in Uganda. In 2010, Brian received an achievement award from AED Satellite, the Center for Health and Information Technology, for work related to strengthening health information systems in Uganda using African access points and mobile devices. He has served on the Council of the Free Software and Open Source Foundation for Africa as the Secretary General of the foundation, including overseeing biannual summits in Abuja, Nairobi, and Kampala, as well as building Africa-wide networks. Brian also volunteers with the Creative Commons. He has led diverse teams as a co-founder and or in senior management roles with Blake International University, Watoto Ministries, Bunifu Systems, and Kampala Leadership Hub. Quite amazing. My last panelist is Aaron Shapiro. So Aaron is a primary care doctor focused on providing quality healthy care in underserved communities. He was a fellow in 2011-2012 with the Gardens for Health International in Rwanda. He received his medical doctorate degree from Appet Medical School of Brown University and recently completed his residency training in primary care social internal medicine at Montefiore Medical Center in the Bronx, New York City. His clinical practice is centered in providing personal-centered, non-judgmental primary care based in harm reduction and liberation medicine to offer holistic health care to people struggling with substance use disorders and chronic pain. He received his Masters of Public Health degree with a focus on health leadership and management from the Johns Hopkins School of Public Health. And he received his evidence-based design accreditation and certification from the Center of Health Design. His practice focuses on professional collaboration to systematically improve healthcare delivery and patient experience. He strongly feels that the tools for health technology, healthcare management, and patient-centered design can be powerful tools for healthy justice work. Aaron recently moved back to Washington, where he will soon start as a primary care provider at the Unity Healthcare. So this is the largest network of federally qualified health centers and providers of care in DC. DC's homeless population. That's a wonderful background for our panelists during this discussion. We had run the polls in our chat box. So basically I wanted to check, we understand that the, each one of you participating in this discussion probably has in one or the other used telehealth. So we just wanted to check some of the experience that you have, and unfortunately we only have 2 answers for the question that we had put in the chat box. So we'll proceed in this way. So telehealth, as we know, basically involves the use of digital technologies to deliver medical care, health education, and public health services by connecting multiple users in separate locations. Mainly is to ensure that people have access to health services that in one way or the other would have been gotten if they had the in face-to-face meeting with the healthcare providers. So basically, we hope that after this conversation, all of us will have a better understanding of telehealth and how it can support the achievement of health equity. So let's go to each of our panelists to share a little bit of their work in telehealth, and we'll start with Aaron. So Aaron, I think from your background, as already said, you are a primary care provider. So can you please tell us more about what you do as it relates to telehealth, and as a clinician, how do you think your patients benefit most from telehealth opportunities? Over to you, Aaron.
Yeah, thank you. And it's a pleasure to be here. It's nice to, a decade into my working with Global Health Corps, to still be part of this community and to see how much it's grown. So I appreciate everyone on the call, seeing some familiar names, and it's just a joy to be part of this. And I'm glad that we're talking about this because it's such a critically timely topic. So I am a primary care doc, and I did my primary care residency in the Bronx in New York, which was one of the United States epicenters of the first wave of COVID. So I think it's, we'll definitely get into talking about that, but I think it's important to kind of just contextualize what telehealth is, and what those benefits are and why we're even talking about it. And I think that context is that historically, medicine is a very, very old field, and how people access healthcare is stems from a very old model where someone gets sick and they go physically to the doctor, or the doctor physically comes to them. And my profession is one that's very slow to change. We have our own ways within healthcare that we kind of say, hey, this is a worthwhile thing to do differently, but that's rare in medicine. And so one of the things that I think is important to think about with telehealth, and a lot of you identified this in the poll, is that a lot of telehealth is all about access. And healthcare, my profession, is one with immense power dynamics, that there's a lot of gatekeeping in medicine, and there's a lot of power dynamics simply by the fact that patients, people who are seeking healthcare, come into healthcare spaces, come into hospitals, come into clinics, come into doctors' offices. And that creates an immense power dynamic where it's really my profession that holds a lot of that power. And so what telehealth essentially does is it changes that power dynamic very dramatically. It increases access. It empowers patients to access healthcare on their own time instead of waiting in lines, waiting on hold to get appointments, depending on just one person to let them into these conversations about healthcare. It allows regular people to access healthcare on their own terms. And that is in terms that we are now normal to us. But again, my profession is slow to change. So most people think about telehealth as video visits, but it's also using the telephone, text message, phone apps. So all of these tools that we regularly use to make our lives easier, more efficient, more accessible to so much information and communication, what telehealth is doing is essentially saying, hey, healthcare, which is an old profession that's slow to change, it's time to change. So those benefits are increased access, decreasing the power dynamic, empowering patients to engage with their own healthcare on their own terms in their own ways more easily.
Thank you so much, Aaron. That's very great. Just to add one more issue in what you have highlighted. Just in Malawi, when COVID was at the serious peak, working with Clinton Health Access Initiative, we were able to implement what is called now a COVID-19 symptoms triage, which allowed people to be able to dial in using any type of phone, and then check if they have symptoms related to COVID. And at the same time, when they provide those symptoms, the tool was able to advise people on what to do based on what information they have provided to the tool. So that kind of telehealth initiative allowed people, to be aware of what's going on in their bodies and actually take appropriate actions that would reduce the further spread of the pandemic. So indeed, telehealth, provide that chance or expand the access to health services across the board. Thank you so much, Aaron. So now turn to Gina. So Gina, you were working with the New York Presbyterian Division of Community and Population Health during the height of the COVID-19 pandemic in New York. That was significant time for transitioning people to telehealth options. So please share more of your work and where you saw challenges in that transition and how your team overcame that. Thank you. Over to you, Gina.
Yeah, thank you so much, Jonathan. So, one thing you mentioned in my bio is that I had started working on our telehealth program prior to the pandemic. And so we had a narrow window where the focus of our program was really different. And I'm glad that Aaron talked about, what is the promise of telehealth? What are the different modalities? And so, back in 2019, we were really looking at it as a way to open up access and to fill different gaps in care that weren't being met within a traditional model of office visits. Now, once COVID hit, that took on a whole new pressure. And so we were applying these solutions in different ways. And so I'd say there were probably 4 key things that we did within our division in terms of the work. One that I think is very commonly known is just the rapid scale up of video visits. So we want people to be able to be seen. We don't want to lose continuity of care, but we don't want you to be coming into the office, and we want to avoid potential exposures. So that's been, I think, very widely understood. Most people have probably experienced that in their own lives as patients. But we also did some other things using telehealth. So one that was actually really similar to some of the things you were mentioning in Malawi was how we kind of used telehealth in our existing care infrastructure for COVID response. So we, prior to the pandemic, had a clinical triage center, a phone line staffed by nurses, and we were really using that as a way to address primary care access needs. We reworked how that team was functioning specifically for COVID response. So we didn't want our patients to just, be walking up to the practices or walking into the emergency department and potentially exposing themselves to the virus in those very early days. And so we, we're using both phone calls, triage questions on the line, and rapidly routing people to video visits to really try and create a little bit more of a remote triage system and get people cared for remotely. We also did some interesting things with loop closure. So one thing that was interesting for us at NYP is that while my focus was on the outpatient world, we're part of this broader system. And so we felt the tugs and pulls of what was happening in the ED setting and in the inpatient setting. And so when we would see patients who would get tested outside of emergency departments and test positive for COVID, but get sent home for just sort of at-home monitoring, we would make sure that that very same team of nursing staff was following up with those patients remotely and doing some of that loop closure. Same thing for ED discharges. And so we found that that sort of remote care team was really able to use these solutions we're talking about from end to end. And then lastly, we also, we're doing some of that work I described before, which was using telehealth to fill specific gaps in healthcare. So for example, we operate 2 practices specifically focused on caring for HIV patients, caring for patients on PEP and PrEP. that team had a lot of concerns about how do we care for our patients specifically and their ongoing healthcare needs amidst this pandemic? How do we focus on things beyond just COVID-19? So I think they're a great example of what we did in many areas of using telehealth to make sure that we were continuing to care for our patients. And so one really interesting thing we did was we paired video visits with a new at-home testing workflow. So for our patients that needed to be going through routine STI screening, we began sending them at-home testing kits, and we would pair that testing with a video visit. So the care team would walk them through, how to do at-home test collection. We'd walk them through how to send those samples back into the lab. We'd use secure messaging through our patient portal, and really we're able to replicate a lot of what we would do with people walking into the practice without people, ever having to come in. And so it was a really interesting thing for us to test out there. And there are a lot of examples where I'd say the unbundling of our traditional care model allowed us to be flexible in different ways. So that was the work. I'd say the key challenges that we faced are ones that, I think we're probably going to touch on a lot in this panel. So telehealth has really amazing benefits when it comes to accessibility. It also has challenges too, whether that's related to, how comfortable you are with the tools, how easily designed those tools are for people to use, what devices do you have or do you not have? Is your device even functioning right now? And then what is your connectivity level? So that was something that we knew would be an issue from the get-go. For our system in particular, we had just transitioned to a new medical record, a new patient portal. And so even if we had been, all of our patients would have been pros, it was brand new to them and to our care teams when the pandemic first hit. And so one thing that we did a lot of that I think is really crucial was patient support. It's great to, say that you think people are going to figure it out. We knew for our division, you mentioned, we primarily serve Medicaid and Medicare patients. Many of our patients do not speak English, and a lot of these tools are not as well designed in languages other than English. And so we really had to reach out to our patients first to make sure that we were walking them through how to access these solutions and not let their ability to access care be determined by their technical proficiency or device access. We started reaching out to patients before they started appointments, things of that nature. Can definitely get into what that support model looked like a lot, but we had to ramp that up. And then I'd say the last two were systems improvement. So on the technical side, improving the fidelity of our video visit system, our portal, and also really trying to find ways to improve accessibility as we encounter different problems in the user experience for patients. And then lastly, I think the obvious one is that there was a whole lot of workforce training that went into ensuring that we were able to ramp up in all these different ways. These were new tools for our care teams, like Aaron was mentioning. And I think making sure that people weren't just comfortable with the technicalities of what was being asked for them, but that they felt comfortable in being able to deliver care, use their clinical judgment in a way that felt authentic, and they were still able to preserve, how they would want to care for patients, just in a new modality was really important.
Wonderful, 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 Gina. So our next panelist is Brian. So Brian has already said you're working with the medic. So we would like you to share with us more about your work in telehealth and setting up systems for community health programs. So is telehealth something that will only work well in settings with high connectivity, or is it something that we can adapt to anywhere and it can benefit the patients no matter where they are on the grid? Over to you, Brian.
Thank you, Jonathan, and glad to be here, everyone. At Medic, we really work and immerse ourselves in digitization for community healthcare work. The last 10 years of our work has been around the Community Health Toolkit, which is now a digital public good that's available for partners, for governments to use rich places, and they provide care at the door. And that's a significant game changer. I think both Jenna and Aaron have already alluded to that gap that sometimes is uncovered for people who can't reach the facility. And this is where community healthcare workers really come in handy. And we've spent our time working the tools that were significant in leveraging telehealth and digital health overall. And we support them really to improve the quality of care, the decision support mechanisms for community health workers, many of whom would be low literacy, but are still willing to serve in their communities. We do this through partners and of course with governments. Well, typically the enabling environment much more than just usually the apps and services that we think about. So typically we'll be drawn to the applications, the servers, the standards, interoperability and infrastructure. But I've come to realize it needs to be great for digital health to work around the world. There's communities that are truly still off the grid. There's communities that are still very hard to reach. And this is the place where telehealth becomes a game changer. A mobile hand in this home and can work offline. That is a huge UHC. Can we adapt this no matter where people are? Yes, absolutely. Because we want to provide care in everywhere. Every human being needs to be able to have access to care. We want to be able to under partners in health. These people are making something look very good and very easy to do, and design the tools that fit this context and support the deployment for these tools. If we did that, yes, there will still be people who appear to be off the grid, but they will not be unreachable. And for healthcare, that's a big vision, and I think one that we should all be proud of. Jonathan.
Thank you so much, Brian. Of course, I had some difficulties hearing you. I think the connectivity on that end, either my end or your end, was affecting the audio. I'm not sure if the rest of us were able to capture what Brian was saying, but thank you so much for sharing that amazing work with our participants to this discussion. Moving on, I think as GHC alums, we are all deep advocates of health equity and care deeply that our work in public health promotes equity and access to quality care. The COVID-19 pandemic, led to an unprecedented increase in the use of telehealth across nearly all medical areas. I think our panelist has, quite often explained different settings where telehealth has, made a serious contribution in supporting the COVID-19 pandemic. So additional to providing essential medical services during the pandemic, indeed telehealth has the potential to expand healthcare. So can you describe the role of telehealth in bridging the health equity gaps and expand access to care during and after the COVID-19 COVID-19 pandemic. We would like to hear from our panelists, Aaron and Gina, your comment on that. Over.
Yeah, happy to. So I think it's important to note right from the get-go the injustice and inequity in our healthcare systems globally. And I think everyone on this call is well aware of that. I think the COVID pandemic just highlighted a lot of what that was, as any global health crisis would. And I think it's important to note that broad implementation of telehealth services was already quite common in wealthy healthcare settings, that this was a technology. There are healthcare startups that are exclusively focused on telehealth through health technology. And for a lot of wealthy communities, this already existed. And the pandemic, as far as a lot of those regular health service delivery systems, didn't change all that much. There was some change, but not nearly as much as we saw in under-resourced, underfunded areas. And so, as Jenna alluded to, there were these huge ramp-ups of attempts to adopt telehealth, which in many sites had never been done before. So people for the first time were downloading apps to their phone. There were conversations about whether or not people had app access on their phone. Doctors were being trained in things or not trained in things, just expected to use things. And nurse practitioners and physician assistants and nurses were all expected with minimal training to adopt these new technologies very rapidly, which was a clunky rollout. And the investment in a lot of that training and overhead and strategy behind it often wasn't invested in all that much. So I think all of those things really just highlighted the inequity in these things, in a lot of these healthcare settings. But I think what came of it is it had the potential, and still has some potential, to be a large equalizer. To say that, hey, no matter where you are, the vast majority of people at this point have some access to technology of some sort, to a telephone. And that allows for increased access. And one thing that I would be kind of remiss to not mention is, especially during the first waves of COVID, when we were really not allowing even family members into hospital rooms as people were very sick and dying, those of us who were in those rooms used iPads and our own cell phones, and whether it was through Skype, Zoom was being rolled out, or just FaceTime, our own video personal applications. That's how we got families into hospital rooms to say goodbye to their dying loved ones. That is an implementation of telehealth as well. And so I think the kind of, for me, this was this huge magnifying glass and exposure to the inequity in access and capacity to roll these things out. And my hope is just that the things that we've learned, the potential for increasing access, the potential for equalizing how people have power to communicate with their healthcare providers, doesn't get lost as we kind of get more comfortable coming back into offices and into the old ways of doing things as well.
Yeah, thank you so much. I really agree with you. One case in Malawi, when COVID, during the first wave, when lots of people were dying, I think for me, it was the first time to see so many players coming together to figure out a way of, having a common ground to support the efforts, to make sure that, most people are being assisted. I think for the first time, like the Minister of Health in Malawi, especially on the digital side of things, pulled out all the partners to make sure that either resources either in funds or expertise were actually put together to make sure that we're moving in one direction. So you could see people working together, like on the system side, we are developing systems day and night, integrating systems to make sure that data is connecting from one system to the other. And then the ministry is having access to what's going on the ground and rolling out different telehealth initiatives, the WhatsApp chatbots, and so many other things. You could feel that I think COVID is exposing our gaps in terms of coordination, in terms of putting resources together to make sure that things are happening. So indeed, telehealth, is a tool that obviously has the power to breach the iniquities that are happening across the board, not only to patients, but also even to people in leadership and people that are doing something on the ground. Yeah, so telehealth provides, an opportunity for undeserved communities to access health services by eliminating traditional barriers to healthcare, like transportation needs, distances from specialized providers. However, it also could exploit existing disparities if the obstacles to care for population experiencing these disparities are not addressed. So what barriers limit telehealth utilization and implementation experiences for under-resourced communities? Our panelists, Brian, what's your comment?
Thanks, Jonathan. I hope this time it's better. And sorry about earlier. I think for me, coming to this conversation as a digital practitioner, the first thing that I'm drawn to is the enabling environment for telehealth overall. Recognizing that digital solutions and telehealth innovations do not sit in a silo. They do not live in a vacuum in and of themselves. The enabling environment includes strategy and investment, policy and guidelines, and the healthcare provider as a workforce, having the right skill set to actually take advantage of and use the digital health or the telehealth alternatives. And all of this is nested, within very strategic and intentional leadership and governance. And so when I think about barriers, it is easy as a digital practitioner to think the barriers related to the physical stuff within the tech, but I've just come to open my mind more and more as I could do this work to recognize the barriers could come from any one of these areas. And if we do not invest wisely, we could lose the fact that we have the infrastructure facilities in the places, but our investment isn't aligned with infrastructure plans for government for certain regions and areas. And as a result, we're not able to take advantage of any new resources that are being taken into areas, especially areas that are far from traditional healthcare structures. And that for me is a key thing. I think opening our minds now to recognize that tech is very fast and it's going up very quickly. And so every 2 years, there'll be something capable and something new, but tech will not exist in and of itself. It will live within a comprehensive environment, and we need to look at all those pieces. Otherwise, the barriers we're dealing with could come from anywhere in those buckets. Back to you.
Yeah, thank you so much, Brian. Very, very true. So, Gina and Aaron, what are the strategies to address the disparities in telehealth? Any thoughts around that?
Yeah, thank you, Jonathan. And, I'd really quickly just want to mention some of the ways that telehealth can bridge equity gaps, since that was a question you posed before. And I think that the two are closely related. I'd say that there are so many barriers that people face in traditional care delivery. There are also barriers that people face in virtual care delivery. And so there's an interesting interplay between the two of them that I think we see a lot. I think that's going to shift over time as well. So if you think about your experience as a patient, I think there was a mention before about just the linkages and loop closure and where that can drop along the journey. When you are a patient, particularly if you have a chronic condition, you're seeing multiple physicians, there's a lot of burden that is put on you. You are traveling a lot, and there's not a great deal of coordination always in communicating between all those different members of the care team. And so I think we've seen some really positive improvements there. in terms of people being able to do some follow-ups from home and reduce that burden and travel time. There are a lot of ways that family and caregivers haven't always been able to, be included or participate in the care of their loved ones. And it's a lot easier for them to do that now with telehealth. And we know that that's important and supportive. And then, I think a lot of these other modalities that we haven't gotten into as much, or any consults or in other ways, are ways that we've been able to really open up access to areas of healthcare where there are traditionally very, very long wait times just to even access that care, let alone get into the experience of it. And so I think, I want to just call that out there because these are all really important things for health equity. And so it's really important that we also think about addressing disparities in access so that those benefits aren't distributed so unevenly. And so in my mind, I'd say the solutions are really around two prongs. One is about people and one is design. So people is what we've done a lot of to date, in my experience, where we have our solutions, we're tinkering with them and trying to improve them bit by bit, but we really have to do a lot of extra work intentionally to make sure that, in my experience, that we were reaching our patients and that we were reaching our patients who are most likely to struggle with taking advantage of different telehealth solutions. That was it needed to be a very active and proactive effort. And so making sure that, we were pairing patients with a community health worker, that we were teaching our community health workers about all of these different tools, it was really important. And I think that another thing that I feel deeply is that we can't treat these as, episodic bits. So what was great about working with our community health worker team is that the teaching you how to use a portal, teaching you how to connect to a video visit or manage all of these different parts of the telehealth access piece was just part and parcel with the conversation you were having about your healthcare. In my experience, having a conversation with the patient about, telehealth access, navigation in isolation is not particularly helpful or motivating if it's not tied to what broader healthcare needs they have. But when you're talking to somebody about, the wait time to see the physician that they've been trying to reach, or the fact that they have a question and they don't want to wait on the phone really long, that's when it becomes helpful to introduce these modalities and tools in context with what actually matters to them and the needs that they're presenting with. So I'd say that there's the people piece. And then the other thing that I really want to underscore is the design and the tools themselves. It's really important that healthcare continue to adopt digital solutions because we do have so many long-standing barriers in access. But just, kind of throwing technology at people is not going to be the solution if those tools aren't designed in a way that is easy and intuitive for people to use. And I think it's really important that we recognize that we're in a place now, and we're going to increasingly be in a place where, phrases like user experience that we talk about in other areas of our lives, that is part of the patient experience. And so, it's not just enough to say that we're going to do extra to close gaps in equity. We need to look at the products and services that we're putting out into the world to make sure that people are actually able to, use them more fluently, don't need that additional level of support in the same way. And that we're looking at sort of the broad spectrum of who our users are when we are even designing those solutions to begin with.
And I'd like to chime in also. I couldn't agree more that way, way, way before the COVID pandemic, the first I ever heard of telehealth was actually in rural areas, that it was the ultrasounds being used by extension workers to prevent young pregnant people from having to travel hours to a large city that they may not have needed to make that trip while they were pregnant. Or it was community health workers texting with clinics and with patients directly to coordinate care out in the field. And at least here in the US, we're actually late in the game to adopt a lot of these technologies. And I think from my end, one of the biggest barriers, if not the biggest barrier, is that a lot of power in at least the United States health system is with the physicians, it's with my profession, my colleagues. And we, as I mentioned, are very slow to adopt change. And I think we kind of take these like randomized controlled trials and these huge, like our societies need to make these huge article kind of publications about certain efficacy of intervention. And we are often the ones who honestly need additional attention and training to say, hey, like, this is why this is important. This is what helps. So I, in my clinic, for example, through my residency, realized a lot of these barriers to the user experience, the design, not only in our buildings and how people engage in the place, but also with technology. And I started an organization called Differential Design that looks exactly at those user experiences, not only from the patient side, because I often find that the patients are actually quicker to adopt these things because they're so obviously beneficial, but also from the provider side, from the administrators, from the people who are the front desk workers, nurses, physician assistants, nurse practitioners, and physicians, that we're often the ones who need the most help to understand why these are important. Because in healthcare, we're such a siloed profession that so many people go from undergrad with pre-med to medical school to residency to practicing without engagement with any other professionals, which is rare in the line of work that I think a lot of people on this call are used to. But I think it's really important to understand the cultural microcosm of healthcare professional training, which is that we're only around like colleagues. And so to introduce technology and ways of doing things and a design that is birthed from other professions by other professionals, it's really hard to get that into my professional kind of bubble of respect, but it's well worth the investment. And I'd be happy to continue having that conversation with people about that intersection of bursting that siloed bubble.
Yeah, thank you so much, Aaron. That's really helpful. Back to Brian. Very briefly, Brian, telehealth in terms of capturing data, monitoring health work progress, diagnosis, and utilization has been an active area of focus in many low-income areas and within rural health settings, particularly with healthcare workers for decades now. So in that case, is it, it's not really new with the COVID-19 pandemic. How do you think COVID-19 changed the area of telehealth that we were already implementing? You know, do you have anything we should keep up, we should keep on or go back to, Brian?
Thanks, Jonathan. A couple of things come to mind for me. I think suddenly, I remember when the lockdowns began, I was just returning from Nepal, and I'd just come through the airport in Kathmandu, and they already had this COVID sign-up sheet where, you know, they're checking all the details. And around Feb, you'd gone through a couple of airports and you're experiencing this. If you think now, what happened to that data set? You know, what happened to each of those little paper forms that was exclusive to COVID that you filled in at some point in some transition station? Where's that data sitting? I think for me, the first thing is the pandemic really brought to light the fact that we still implement systems that are siloed, where the data sets are not intended or built for interoperability. And we started to recognize quickly that, yes, we knew individuals because they were human beings and they were somehow connected to our care. So they were not new at all, but we didn't have additional information about them. We didn't know their household context. We didn't know anything more to help us provide care to them. And for me, I think that's the first shift. We've got to go away from the siloed data sets to a really integrated digital health enterprise, because the data has turned out to be very useful, but we can't continue to see data in pieces and in slices when it comes to providing holistic care for an individual. The second thing that comes to mind is access. True, during the pandemic, we really began to interact with our healthcare providers through all these gadgets and devices. But let's really unpack what access is like and as a challenge. And I know Jenna started on this. Think about devices, you know? How many people in your community have that first initial device that they're going to use to probably create that first channel of interaction? How many people have lasting connectivity? But also, assuming we've managed to get over those two, we now have this face-to-face interaction. So I have a video, I have an image. Google recently was in the news for blocking a parent who shared photos of their child because they were interpreted as child pornography. And this guy was truly simply executing an interaction with a healthcare provider. So what happens to all this data and the safety and security of healthcare data that's crossing over these channels? And have we had a good enough conversation about what this means and the implications? But also very, very basically, the skill. How many people were actually ready to start using a computer? How many people were ready to put a webcam on their laptop and just open themselves up to that interaction? And then finally, I think the pandemic, everything we know about the pandemic was held largely in places where there was a health facility. The facilities that remained open and were able to serve, taking admissions, we learned a lot about the pandemic and its effect in those contexts. Now think about the people who never made it to a facility. Think about the community level impact of COVID-19. I think we need to go back to that household view, that UHC mode view of looking at our communities, because for some people, they will not arrive at that facility and we're going to lose them, we're going to miss them. And if we don't think about that, it's really going to not give us the gains that we're hoping to receive as we provide care and as we take advantage of how telehealth can leverage these challenges in connectivity. Jonathan.
Thank you so much, Brian. That's very insightful. So Anita, do we have any questions in the chat from the participants? Or can we have a chance to have a question from one of the participants?
In the interest of time, maybe if someone has a question, you can just raise your hand and you can go ahead to ask it. If you're comfortable chatting, then just feel free to chat in the Q&A box.
I'm happy to jump in while people are getting their questions going. Thank you so much, panelists, for this amazing conversation and discussion. I've learned a lot, and over the last couple of years, it's been amazing to see the boom of telehealth and such. One of the things I'm really interested in is how do you see the future of telehealth perhaps expanding, borders and maybe not being as country siloed? One of the things that we see right now is it is sort of in each country or in kind of each jurisdiction that you're talking about. But one of the benefits could really be areas that don't have access to perhaps specialized care. How do you see some of that changing with this kind of growing field, and maybe where do you see some of the barriers that people on this call who are health equity focused might be part of reducing those barriers?
Yeah, thanks so much for that question. Brian, would you like to take a first shot?
Yeah, I think coming from the global south, the sort of immediate consideration that comes for me is while our colleagues in the global north, I think, might have been dealing with, the presence of infrastructure and technology in some way or shape or form, we are simply starting to unlock this. So mobile penetration is still very low. Internet penetration is still very low. We still have a lot of censorship from our governments and leaders. So if you ask me, what's the future from how I see it and from the community that I sit in, when I think about opening it up a little more, it's not very strong from where I sit because I do not yet see a truly significant reach and coverage for these solutions. If I think about our healthcare workers at different facilities, particularly remote facilities, many of them are coming to grapple with the first electronic medical record platform. You know, it's the first they're finding on the ground, and they have one desktop, and it's shared between 4 or 5 clinicians to work with. And so I think the Global South might have a slightly different set of challenges, and the future then really does look a little bit different, perhaps than from our colleagues who are in places where maybe we're dealing with acceptance, but the infrastructure and the tools and the gadgets are a little more prevalent, and therefore we're able to start from somewhere. That's just first consideration.
Yeah, thank you, Brian. We have one more question, especially to do with the role of government in evaluation of the telehealth. For example, what is the role of the ministry, you know, when it comes to evaluations? Very quickly, we running out of time. Over, Brian. Oh, Gina, or Aaron, if you have something to say.
Very briefly, and then I'll turn this over to Jenna. I think in our case, the Ministry of Health is a custodian. So we work in support of the ministry as national priorities. And so the leadership and governance part of the community health information system, as we have deployed it in countries in Malawi, in Uganda, in Kenya, that custody is exclusive to the Ministry of Health. Our data protection guidelines and compliance is handled exclusively by the Ministry of Health. And so as implementers, we are really working in support of, and we recognize the ministry's roles in providing that leadership and governance, and also the policy and the guidelines that through which both digital and health implementing partners would operate to make this possible.
Yeah, thank you so much. Yeah, go ahead.
Sorry,
Very
Jonathan.
briefly.
I would echo, Brian's label of the government as a custodian. I think it also has a really important role in setting the right incentives. So I think we've seen that in the US a great deal. One big reason why telehealth exploded in the US during the pandemic was not only because of the real need that we were experiencing in care delivery, but because reimbursement policies were changed. And so we saw that really move how systems chose to adopt telehealth. And we're seeing that, modify their behavior now. I'd say another thing, kind of to the question earlier about geography and boundaries, and this isn't limited to, I'd say any one particular government, that where they also have an important role is in licensure and regulation. This looks different depending on the country that you're talking about. Here in the US, there have always been restrictions around, where are you licensed to practice and what does that mean in a virtual context? And so that was really loosened. We're seeing that tighten up again, now that we're, 2 years removed from those early days of 2020. And so that also has a really important role in how telehealth can spread or not. And the government has a really, I think, important role to sort of encourage system, regional, geographic collaboration to address access.
Yeah, thank you so much. Anita, I think for the interest of time, I think that's what we had for today. Please, over to you for closing remarks.
Thank you so much. That's all the time we have today, as Jonathan has mentioned. But I want to say thank you so much to our panelists. This has been an excellent and informative session. I want to say a huge thank you from GHC to our moderator, Jonathan, and to our panelists, Jenna, Brian, and Aaron. I appreciate your time and the insights you have shared with our attendees today. Thank you so much. As a reminder to all our GHC community members, please share your insights, research, learnings, questions, all the support you and your teams need on the community portal to keep this conversation going and to share the wealth of information we have in the community. Thank you again to our panelists and to Jonathan, our moderator. We wish you a great rest of your day.
Thank you so much. Bye-bye, everyone.
Bye.